is a short voiceover regarding the intracranial pressure content. So ICP is the hydrostatic force that's being measured in the brain CSF compartment. It's the hydrostatic force that's being exerted against the cerebrum within the cranial cavity. So understanding the dynamics associated with ICP is important when you're caring for neuro patients with problems. So within the cranium, which is a closed box, there are three volume components. The brain tissue, which makes up the majority of the cranial cavity, the blood, and the CSF. Like we said, the cranium is a very rigid structure, and it minimally compensates when we have a rise in ICP. So factors that influence ICP, and this is going to determine also how we care for patients who have rising ICPs. So we know arterial pressure. Arterial blood flow is what we need to maintain cerebral perfusion pressure, tissue perfusion, when we have increases in our intracranial pressure. Intra-abdominal pressure, intrathoracic pressure, both of those situations, when there's an increase in them, can actually increase ICP. So when we focus on decreasing ICP or maintaining it, we're going to look at some different techniques that we can do to minimize the intra-abdominal, intrathoracic pressure. Posture, temperature. So if we're hyperthermic, our body temperature is too high, our metabolic rate is too elevated, especially in situations where we're not getting enough perfusion, enough blood flow with oxygen, glucose, we're going to have an increase in anaerobic metabolism, metabolites, byproducts, and we're going to have a more acidotic environment. And so those factors are going to influence ICP because they can actually cause the cerebral vasculature to dilate and increase kind of the blood flow in that area, which in that situation is not a good thing because it can actually lead to more edema, swelling, and a rise in ICP. So we don't like our blood temperatures to be very high. So blood gases. Carbon dioxide is considered a cerebral vasodilator. And so with CO2, we like our pH to be somewhere between 35 to 45. We don't want it to be too high or too low when patients have ICP because CO2 is a cerebral vasodilator and it can actually increase our ICP when we don't want it to. So causes of increased ICP, like we said, if there's an increase in any of the three components of the cranial cavity, brain tissue, blood, and CSF, especially when one of them increases yet the other one doesn't decrease to maintain that optimal ICP. So some other things that can lead to the alterations in these components: brain tumors, hematomas, whether it's an epidural, subarachnoid, or subdural, hemorrhage, contusions, or a cerebral infarction from an ischemic stroke, especially if it's large enough and we have a large amount enough of cerebral edema from the necrosis afterwards. So the Monroe-Kelly doctrine says that if one compartment within the cranial cavity increases, another must decrease to maintain optimal ICP. This doctrine obviously isn't appropriate when you have an open cranial cavity with a craniectomy. But so the Monroe-Kelly doctrine stays in play if we are able to optimize our ICP and maintain it within that normal range of 5 to 15. But when we're not able to compensate in another area of the cranial cavity to maintain optimal ICP, then we're going to see a rise in ICP. So, like we said, normal is 5 to 15, but anything greater than 20 sustained is a problem and it needs to be treated. So normal compensatory adaptions. So changes in cerebral spinal fluid volume. Okay? So if we have rise in blood flow, blood volume, rise in brain tissue, we're going to see changes in CSF to maintain optimal ICP. If we have changes in intracranial blood volume, we're going to see alterations, hopefully, in the CSF. And if we have changes in tissue brain volume, we're going to see alterations in CSF volume and intracranial blood volume in order, hopefully, to maintain optimal ICP. But there's limited ability to compensate. So if the volume increases and it continues and the ICP rises, decompensation can occur. We only have very limited ranges of compensatory adaptations with rises in ICP. And without them, when they're lost, then we lead to decompensation and eventual herniation. All right. So cerebral blood flow, cerebral perfusion pressure, very similar to when we talk about tissue perfusion in patients who have shock. It's the pressure needed to ensure blood flow to the brain to make sure that we have aerobic metabolism and that we're not leading to ischemia and infarction. So we need an adequate cerebral perfusion. And so how do we get that? Well, it's our mean arterial pressure minus our intracranial pressure. So our mean arterial pressure, we know, is kind of the average arterial blood pressure at the tissue level. And so how we get a mean arterial pressure is to take the systolic blood pressure plus 2 times the diastolic blood pressure and divide it by 3. So anything greater than 60, 65 really is optimal, but you can get too high. But the cerebral perfusion pressure is the mean arterial pressure minus the ICP. Now you're going to have more of a minimally or an invasive device monitoring the ICP to be able to determine your CPP. A normal cerebral perfusion pressure is somewhere between 60 to 100 is optimal. Less than 50 is considered ischemia. And I think once we start to get less than 30, we start to really worry about brain death and incompatibility with life. And so, like we said, factors that affect cerebral blood vessel tone and cerebral vasculature, carbon dioxide. When our CO2 is high and our pH is low and we have an excess of hydrogen ions, they're considered cerebral vasodilators, but they're not really a good thing in somebody who has rising ICP because they can actually increase ICP. They don't optimize cerebral perfusion pressure like you would think. Okay? So when patients we don't want our patients to be acidotic. We want their CO2 and their pH to be optimal. We don't want it to be low or high. With oxygenation, low oxygen is actually considered a cerebral vasodilator as well. However, we still know we need a lot of oxygen to maintain cellular metabolism, energy production. If not, our tissues turn to anaerobic metabolism, again, increasing our risk for an acidic environment. So, like we said, maintaining optimal CO2, maintaining optimal pH. We want to keep these patients somewhere between 80 to 100 and maybe a little on the higher side of the oxygen dissolved within our blood. So clinical manifestations with rising ICP, a lot of this is going to overlap with the head trauma, the stroke. Change in level of consciousness is the most sensitive indicator of neurostatus and declining neurostatus and rising ICP. So changes in that Glasgow-Coma scale, flattening of affect, coma obviously at the end of the spectrum with altered level of consciousness. Changes in our vital signs, we said Cushing's triad. As ICP is rising and our blood pressure rises to compensate to maintain cerebral perfusion pressure, we're going to see Cushing's triad. We're going to see a rising systolic, widened pulse pressure, a drop in our pulse, bradycardia, and bradyapnea, so a decrease in respiratory rate from the pressure on the brainstem. So some of the clinical manifestations that we're going to be looking at is if cranial nerve 3 has some compression, the ocular motor nerve, we might see ipsilateral pupil dilation on the affected side of the brain. Okay, so on the area maybe where there's the hematoma or the infarct that's leading to the rise in ICP, We're going to see pupil dilation, so we're going to see unequal pupil sizes, possibly a fixed dilated pupil or a blown pupil. Sluggish, so there's no response to light or minimally responsive to light. There's going to be a decrease in extraocular motor movements, eyelid ptosis. We might see diplopia, okay, double vision, blurred vision, headache. Typically, if this is because of a rise in ICP, a continuous headache that definitely is worse in the morning and gets worse with any type of activity such as bending down, coughing, sneezing. Vomiting with ICP, usually it's considered projectile and it's without nausea. And then we might see some of the motor deficits, hemiparesis, hemiplegia. Posturing, you've got decorticate and you've got decerebrate. This is decorticate and this is decerebrate. These are usually poor indications, kind of ominous signs that the ICP is rising and that it's getting ready to herniate. We'll see these as well. Sometimes patients won't posture just spontaneously. They're going to posture with noxious stimuli. So you go to suction them. You go to, do a pain stimuli to elicit a response. Do some sort of care. So touching them might elicit a posture. So decorticate, decerebrate. Complications from increased ICP that's not taken care of, obviously, in addition to inadequate cerebral perfusion pressure and brain death and worsening of the damage, we're also going to see cerebral herniation, right? So we only have very minimal places to go. And then once the ICP gets too high, we're going to have to shift. And so we could shift on the midline or we could shift down through the foramen. So diagnostic studies, like we said, CT scan is probably the gold standard. It's quick, it's available. MRI is more specific, but we know there's going to be a little longer of a wait time. But they both can diagnose kind of the underlying cause, maybe evaluate treatment, look at the progression of the problem. EEG, so in these patients where we are determining whether they're brain dead or not, we might look to get a neurology consult, and they might do an EEG to assess for brain activity. Now, we know with lumbar punctures, if patients need one with a possible stroke, it can show us RBCs in patients who have got subarachnoid hemorrhages, but we do not want to be doing a lumbar puncture in patients who have rises in ICP. It could cause a sudden release of pressure and actually increase the risk of herniation. All right, so measurements of ICP. So the ventriculostomy system is the gold standard for measurements of ICP. Most of these are going to be able to not only measure ICP, but also drain cerebral spinal fluid in order to maintain optimal ICP. So a catheter, usually by a neurosurgeon, it can be done at the bedside, I guess, or in the OR. It's going to be inserted into the lateral ventricle coupled with an external transducer. So you'll monitor it from a bedside monitor very much like you would do an Artline, CVP, or a Swan. The setup is similar but a little different because you're not going to be infusing saline to kind of keep the system open, right? Because you don't need to, because it's not within a vein or it's not within an artery. We don't want to be instilling fluids into our ventricle where we're going to be just measuring the pressure or removing cerebral spinal fluid. And I guess it does allow drug administration for certain things if we need to. So usually indications is going to be a GSC of less than 8. And then the insertion of the catheter, right, this is going to be done under sterile technique. Lidocaine around the superficial area. There's going to be a surgical incision. They're going to retract the area with retractors. And then they're actually going to do a burr hole, and they're going to insert the catheter down into the area where they want to. All done under sterile technique. And so they're actually going to be securing and suturing the catheter to the scalp. So some things to kind of consider if you've had the opportunity to see some of the arterial lines, the CVPs, the SWAN, you know that a lot of the measurement systems that are on the IV poles, they zero them and calibrate them to the level of the atrium, which is considered the phlebistotic axis. So we do that at the start of shift and with any really grand position changes where we think the numbers might be off and they might not be accurate. But with a ventriculostomy system, we don't calibrate or zero to the level of the heart or the atrium or the phlebistotic axis. We do it to the tragus of the ear. So we do it at kind of the level of the brain. Okay. So when we zero it to air and kind of calibrate the system, we do it to the tragus. So some of the same, things with we would do for an art line or CVP, initially the start of shift or with any kind of grand repositions where we think that the levels might be off. So some things to consider with ICP, right? You're actually within the cranial cavity, within that ventricle. So infection, encephalitis, meningitis, so localized systemic infections. So just kind of like with any other invasive devices, the length of time is going to predispose these patients to infection. The presence of any kind of cerebrospinal fluid leak, that's going to increase their risk for infection and concurrent systemic infection at the time of insertion. So nursing considerations, routine assessment of the site, use of aseptic technique when they're managing the dressing or when they're changing the system tubing to it. Monitor CSF for any change in color or clarity. Those are very important nursing interventions. So infection control, big one with ventriculostomy systems. So in addition to just kind of looking at the numbers on the monitor, we said 5 to 15 is normal. Anything above 20 needs to be treated. There's usually a kind of a stepping stone, a normal waveform for an ICP. And it's usually kind of set up as a P1, P2, and P3. So it looks like a staircase. But when that staircase is lost, it usually is associated with moderate to significant elevation in the ICP level and the waveform. So it should look like a staircase. When it starts to kind of go out of the staircase, when the 2 and the 3 start to come up over the 1, then there's a problem. There's significant elevation in the ICP. All right, so with measurements of ICP, like you said, in addition to measuring for the level, you can actually remove the CSF to kind of maintain the ICP. You can do it intermittently or it can be a continuous drainage. So some things that you need to be aware of is how much drainage are you taking off, okay? So you need to be aware of the parameters for the ICP. So if it tells you if the ICP is at a certain level and they want you to take off a certain amount of fluid, you need to be aware of that. And then you also need to be aware of how much is too much to take off, okay? Because you can actually cause negative consequences with taking off too much fluid as versus not taking off enough. So that's optimal. That's kind of goes without saying. So some other drug therapies to consider with patients who have elevations in ICP. Mannitol, osmotrol is a big one. It's considered an osmotic diuretic. It's also considered a plasma expander. So we're going to give this IV, and it's going to expand intravascular blood volume. So typically what we're going to see in these patients is hypertension, increase in urine output. But the whole reason we're giving it is to pull fluid from the interstitial tissue in the cerebral area, okay? It's an attempt to maintain ICP, okay? So we'll typically see hypertension, increase in urine output, and we need to, kind of look at fluid and electrolyte status. So mannitol is IV to decrease ICP. It's a temporary measure to decrease intracranial pressure. We can also use hypertonic solutions like 5% dextrose. It kind of does kind of the same thing as mannitol, but we also need to be monitoring blood pressure and serum sodium levels and serum osmolality. So some other things to consider, anti-seizure medications, be monitoring these patients for seizures, like we said, a lot of our hemorrhagic strokes, some of our maybe contusions, they're at increased risk for convulsions, seizures. So we talked about Ativan, we talked about diazepam, Valium, Keppra, Dilantin. Okay, so there are emergency rescue medications, and then there are the more ones that we're going to be using for maintenance. Antipyretics, so keeping these patients cool, cooling blankets, acetaminophen if indicated. We don't want these patients temperature high. We want them optimal. Sedatives, analgesics, barbiturates. Definitely now with the rise in ICP, it's not optimal for these patients to be too awake, agitated, uncomfortable, and pain. All of those things increase their metabolic rate, increase the risk for rising their ICP. So keeping them calm, keeping them comfortable is where we want them to be. Lowers our metabolic demand. Yes, these patients are hypermetabolic for whatever reason, whether they've had surgery, whether they've had a craniotomy, or just the trauma or the infection, that what's ever going on, but they've got a hypermetabolic state. And so they do need glucose, they do need nutrition. So, we need to consider, is it optimal for enteral or parenteral nutrition? We know enteral is better. And we want to do early feeding if possible, usually within 2 to 3 days, just like any other patient in the ICU. And these patients, we want to keep them normal volemic, euvolemic. We don't want to be giving them too much fluid to increase that risk of cerebral edema and increasing their ICP. We need to make sure that the fluids we give them are isotonic. We want to give them what they need for depending on where their serum electrolytes and osmolality are. Okay, we don't want to be altering the cells being overloaded or the cells shrinking. So some other things to consider: maintain patent airway, especially if their level of consciousness is depressed. Keep their head of the bed at least 30 degrees. We said this with the head trauma. We also said this with hemorrhagic strokes. Keeping their head of the bed somewhere around 30 degrees maintains kind of a patent open airway, and it's also going to increase venous return from the cerebral vasculature. If we rise them up too high, we have the risk of dropping their blood pressure, altering cerebral perfusion pressure. Suctioning, just kind of like where we are now with patients in the ICU, we're going to suction them as needed. We're not going to suction them routinely. And if we can, we're going to minimize it, because coughing, we know it stimulates them. So if we do cough, minimize it, not so deep. NG tube to decompression. We want to minimize their abdominal distension. Like we said, intra-abdominal pressure can factor and affect our ICP, so let's not rise it. ABG, so we want our PaO2 to be somewhere between 80 to 100, maybe a little on the higher side. And our PaCO2, we want it to be normal, 35 to 45. We don't want to alter cerebral vasculature, cerebral vessel dilation, and rise our ICP when we have elevations in ICP. We said Glasgow Coma scale of less than 8 typically needs to be intubated, ventilated. So we talked about pain and anxiety management. We are concerned a little bit about dropping their blood pressure, alterations in level of consciousness. So some of the medications we use for pain and anxiety are going to be our shorter acting medications that have shorter half-lives, like fentanyl, morphine. A lot of your neuro ICUs, they really like to use fentanyl because it works quicker. They don't have as many of the side effects, the alterations in consciousness, confusion that you see with morphine, and it's out of their system fairly quickly. So if they want to be able to assess impairment, worsening of deficits or improvements, fentanyl is the drug to use. Yeah, benzodiazepines, but we like to use those sparingly because we know they stay in the system a while. In our older patients, they tend to lead to confusion, dizziness. Propofol is a great medication. We use it as a sedative. It does not have any analgesic properties, though, and we like to use it because it's on quick and it's off fast when we turn it off. So it's good and it's ideal for these patients when they're on the ventilator and we're looking to wake them up and assess their level of consciousness. Diprovan also has a fat kind of emulsification in their fluid, so it needs to be changed every 12 hours, the tubing. And we do worry about infection control with the tubing and kind of being lipids and being thick. Precedex is a good medication because it does have a little bit of analgesic in it. Sometimes you can use this medication. It keeps them really calm, and it doesn't seem to alter their level of consciousness too much. In certain cases, if we need to drop their metabolic rate, we need to paralyze them, we can use paralytic agents, neuromuscular blocking agents if appropriate. So this slide is just a little out of order, but when you're doing ICP readings on somebody who's got a ventriculostomy system, like we said, we're evaluating for links. If a patient has an inaccurate ICP reading, there might be a CSF leak. If there's an obstruction in the catheter or kink in the tubing, there might be some leakage around the insertion point. So you might be getting some inaccurate readings. The difference between the actual insertion site or bolt and the transducer system and the IV pole. So we need to make sure it's appropriately leveled with the tragus of the ear, incorrect height of the drainage system, and bubbles and air in the system can actually lead to alterations in ICP readings. So again, just to make sure we're on the same page, things we can do to optimize ICP and CPP, head of the bed 30. Prevent any type of neck flexion. Keep it aligned, straight, and the airway open. If you have to turn these patients, turn them slowly. Minimize their coughing, straining, agitation. Okay? If they are awake and alert and they're able to have a bowel movement, stool softeners, minimizing their Valsalva maneuver. Avoiding hip flexion, because we know hip flexion can actually increase intra-abdominal pressure and rise ICP. So we know our patients with any type of head traumas, brain tumors, they're always at increased risk for diabetes insipidus, SIADH, problems with the pituitary, right? So it can lead to alterations either in too much antidiuretic hormone being secreted or not enough. So we need to be looking at their serum osmolality, sodium level, urine-specific gravity, and their potassium. We know with diabetes insipidus, if they don't have enough antidiuretic hormone, they're going to be peeing massive amounts of urine. Their urine-specific gravity is going to be very low because we don't have enough antidiuretic hormone to concentrate it. So these patients are going to be at risk for dehydration, electrolyte imbalances. They're going to be dehydrated, but they're still going to be having massive amounts of urine output. Their serum osmolality in the blood is going to be high, the serum sodium is going to be high, but the urine-specific gravity is going to be low, and I'd hedge to bet that their potassium is going to be low as well. When patients have SIADH, they're going to have an excess release of antidiuretic hormone, so the urine output is going to be low. Okay? Serum osmolality is going to be low because they're retaining fluid. Okay? And the urine-specific gravity is going to be really high. They might have weight gain, so low urine output, high specific gravity of urine, low serum osmolality. So nursing implementation. Protecting these patients from self-injury. Okay, if there's a lot of confusion, motor deficits, alterations in level of consciousness, seizure precautions. I think we've talked about that a little bit. We've talked about some of the anticonvulsants. Their psychological well-being, judicious use of restraints. Like we said, sometimes the restraints can actually make patients more agitated. increase their risk for ICP rising. So we might consider some soft wrist restraints or soft mittens or things to kind of keep some of our lines and tubings out of their way. Minimal use of sedatives when appropriate, when we need to. The quiet, non-stimulating environment, maybe keep it darkened in the room. Calm, gentle touch, very kind of low, even keel when you're talking to them. And so this would be appropriate for somebody who's at risk for seizure precautions. Bed in lowest position, patient in sideline, like afterwards, I guess, in their post-ictal state. Side rails up, padded, privacy, and then just making sure oxygen and suction is available.